Hi, I'm Dr. Mike Milligan. We're here at Woody Oaks' Excellence in Dentistry Seminar, so there might be some background noise. If you haven't attended that seminar, please do. It is fabulous. There's great speakers. There's great interaction with hundreds of dentists. And one of the key speakers here was Dr. Michael Dorociak from Sarasota, Florida. Michael, thank you so much for being with us.
Thank you for the opportunity, Mike.
Now, Mike's with Gordon Christensen with Clinician's Report. What's your title there again, Mike?
Well, I'm chairman of the board of directors.
Okay.
I'm a project director and a clinical evaluator.
Okay, that's a mouthful, but it's very impressive. And he gave a great talk on the 7 hottest topics in dentistry. Now, why don't you tell us about the 7 hottest topics? There's some of the hottest topics in dentistry, Michael.
Well, we'll start with the curing lights.
Okay.
About half of us probably have a curing light that's underperforming.
Okay.
Well, we're looking somewhere in the 1,000 milliwatt per centimeter squared range for the power and the intensity, and a lot of us are operating at 300 to 500 milliwatts. So a lot of the problems we have with our resins may be related to our curing light.
The curing, not the resin.
Or to our resin, not the curing light.
Okay.
And so what we're looking to now is we're looking to try and find ways to polymerize faster and easier.
Okay.
Fast LEDs are now state of the art.
Okay.
3 to 5 second cure.
I tell you what, I've got the 1 to 3 second cure. I use the I even go 3 to 6. Absolutely love it. I've got a couple of them.
Now, Mike, we're working on some new data now that may say a faster cure may not be as good as a longer cure.
Yep.
So we'll have more information for you next year.
Okay.
But as of right now, sticking with the 3 to 5 second cure is the best.
Sticking with 3 to 5. I've used it for probably 3 or 4 years now, and it does great.
The other thing we're looking at lights that have a large diameter. And is also very ergonomic because the assistant's going to be using the light. So we see that trend toward that. Also, a 90-degree angle is preferred.
Okay.
You know, a lot of our lights are at 70 degrees.
I didn't even know that.
So if you're doing the distal of a second molar, lower second molar, or the lingual of an upper, they're hard to reach.
Yeah.
So a lot of times we may be under polymerizing just because of the
angle,
the inability to get the light.
You want a 90-degree light, which is what I'm using.
Yeah.
So that's good.
The other important idea is that fast lights don't cure as deeply.
Okay.
So now there's a trend toward bulk fill resins, which is putting it all in and curing it all at once.
Right.
Now, if you think about it, you got a 9 millimeter box, basically your average distal box is about 7 millimeters.
Okay.
And so then you add about 2 millimeters for cusp tips.
Okay.
Trying to cure 9 millimeters into that box is almost impossible.
Okay.
So we feel that 2 millimeter incremental cures are still better. I like the bulk fill resins.
Right.
I just don't like how we're trying to apply that, cure everything.
So 2 millimeter, can you go 4?
4 is about what we found to be the maximum.
The maximum, because that's probably about what I do.
Yeah, 4 we found to be the maximum, again, depending on the formulation of the resin.
Okay, so all right, so the incremental cure, 2 to 4 millimeter, 2 best. But okay, got it.
And then we found there were several curing lights that we found in our testing. We tested about 24 lights. Of course, the problem we have when we start testing lights is the minute we start testing them, a new light comes out.
Absolutely.
And so that's always been a problem. But we found that there were several, about 6 of them that were actually rated good to excellent.
Okay.
Savers such as the Demi Plus by Cure is an excellent light. 3M now has 2 lights. They have their S10, which is their first really good light.
Okay.
And they also have the Paradigm.
Okay.
Now we're seeing this with a lot of corporations, is 2-tiered level products.
Okay.
One is the less expensive and then one is the higher expensive. A lot of that, Mike, is in response to corporate dentistry. You know, we got about 50 corporations buying up dental practices, the CEOs demanding lower price products.
Right.
And the corporations are recognizing this.
Right.
Now the interesting thing is when we tested the S10 and the Paradigm, despite their construction, one was a more sturdier construction, they were the same light.
Wow, okay.
I don't mind going on a limb. If I was purchasing curing light today, I would purchase the Velo by Ultradent.
Okay.
I think it's 1 to 3 second cure. It's one of the most powerful lights we out there.
Okay.
One of the critiques was that you used to have a mechanical engineering degree to run it because the controls weren't as easy.
Okay.
They recognize that.
Okay.
We evaluate it and they fixed that, and now it's a lot easier to operate. It's very durable, very sturdy.
Right.
It's a little bit higher priced, but it's curing light. You know, the average dentist does about 9 restorations a day. When you think about 4 to 5 cures per restoration,
right?
You know, I want the best light.
You want something that's going to work and perform well.
Yeah, I want the best light, absolutely.
Okay. Tell me about the heating of the pulp tissue, Mike,
Well, one of these,
with the curing lights.
yeah, with the
curing lights.
fast LEDs, we're finding that 1 to 3 second cure is good.
Yes.
But anything above 3 seconds, it tends to raise the temperature of the pulp.
Right.
Up to about 3 seconds, you're raising the tooth to about body temperature.
Right.
Beyond that, you're going to get up to a 6 to 9 degrees Celsius increase.
Okay. How significant is that? 'Cause
Well,
I've done it. I mean, I've
significant
cured it for 9
enough.
seconds or more.
Significant enough that we have a standard recommendation: light on, air on. That you want to blow air on the tooth when you're curing.
When you're
You're curing, yes,
Okay.
and it tends to keep the temperature down.
Okay.
Or do it in your 3 second incrementals.
Right.
Cure off, cure off.
Okay.
Don't hold it on.
Just don't hold on.
Yeah,
Which is what I do.
And then and educating your auxiliaries, because a lot of times they're doing the curing, and you want to make sure that they're doing it perpendicular to the tooth.
Right.
And you want to make sure that they're doing as close to the tooth as they can.
Right. Okay.
Just this month's report, we're talking about the junk that gets on the light.
Yeah.
And the use of a covering or wrap. It may be important to keep the junk off the light as it is for infection control.
What else? What else do we have here? And by the way, just subscribe to Clinician's Report. I've been a member for probably 30 years.
Thanks, Mike.
And give my age away there, but it's fabulous. You just really need to subscribe.
It's unbiased information. And I'm always amazed. Each month we start out with a topic or different products, and we don't know which product's going to win.
Right. Okay.
We put it through the science. We have over 400 evaluators across the world testing these products, giving us their feedback.
Right.
And then we combine that, both the science and the clinical.
Right. And it's all just straight evaluation. There's no kickbacks or anything like that with Gordon Christensen and clinical reports.
We are truly a non-for-profit agency that really wants to go, and our motto is very simple: clinical success is the final test.
You bet. Yeah, you can just count on them to really give you the skivvy, the straight scoop on those things.
Yeah.
So what else? What else do we have?
I came across, if there was one single thing I can bring home today, if I was a new dentist or an existing dentist, and I said, what one product would I want to introduce into my practice?
Wow. Okay.
It would be the headlamp.
Oh,
the
absolutely.
LED headlamp.
Oh boy.
Loops changed the way I practice.
Oh my.
And now
what
headlamps.
What power do you use?
3.5.
I use 5 power.
And we're showing that the higher power, the more light you need.
Yeah, and my goodness, it's just the quality that I can do, and I know that you can do, is so much better. Get loops and get a good quality headlamp.
Yeah.
So what about the headlamp?
Well, I often joke headlamps pass what I called my stomach test. I remember the days when you didn't have your loops, or your loops broke, and you're trying to operate. Well,
I know.
The other day I was taking out a third molar, and my light went out, my battery went dead.
Yep.
So you had that stomach test of I need the light, even though we asked our evaluators, does it replace your overhead light, and they said no. For me it does.
For me it does.
For me it does.
You bet. I can't tell if the overhead light's on or not if I've got that loop light on.
Yeah, we did find an important recommendation, and this is, to me, one of the values of what the report is that the lights do emit a significant amount of blue light. Between 400 and 500 nanometers in that spectrum, around 450 nanometers is blue light.
Okay.
And to make white light, you need either green, blue, or a combination of both.
Okay.
The eye is protective with green light. It's not that protective with blue light.
Okay.
So the blue light, believe it or not, could lead to macular degeneration.
Okay.
So one of the cautions that we're saying in our early research is don't keep your headlamp on the highest intensity.
Right, I remember reading that.
That's really important, and don't use it for all procedures.
Yeah, okay.
Now there were certain lights that didn't emit as much blue light in the spectrum, and those lights are available in their report. Again, we have 4 criteria when we test the products. We look for faster, easier, higher quality, and if it meets those criteria, then we look to see if it's less expensive.
Right.
There was a headlamp that really did meet all those criteria, and it was Lumident.
Okay.
It's a low entry headlamp, and if I was a new dentist, I might consider
the Lumident.
Lumident. Okay. Air Feather Light really started the trend. It was actually designed by a dental student.
Oh, I bought it right off the bat. I was one of the first purchasers of it, sure.
The trend, trend is definitely toward the miniature headlamps.
Yeah.
It's still an excellent light. We rated it very, very well.
Yeah.
And those were some of the lights. Designs for vision.
Okay.
Is our Ultra Mini, which is also good. One of the key criteria I think that separates designs for vision is that they have a lifetime warranty.
Okay.
Where a lot of these manufacturers have 1 to 2 millimeter, 2-year warranties. We found that maybe half the evaluators did report some problems eventually with their lights that required some servicing. So I think that was another key concept that we had.
Sure, absolutely. Get a good quality headlamp.
Yeah. Another big recommendation is drug information software.
Right.
We got that challenge.
There's so many medications out there, it's really hard to keep track of them.
Yeah, and it's the statistics are amazing. 40% of patients over 60 are on 5 prescription drugs or more.
My goodness.
So now you have your little old lady coming up to the front desk with this crumpled piece of paper and all these medications, and the PDR is basically something to put on my bookshelf.
Right.
It's hard to reference. It's hard to use. And when I'm seeing this new patient, you don't have time to reference all these drugs. This is another Just Get It, and it's LexiComp Online for Dentistry.
LexiComp Online
for Dentistry. Absolutely.
Okay. So just get it.
Yeah, so what we do and how it works in our office is at our front desk, the patient will bring in their list of medications.
Right.
We'll have somebody at the front desk actually enter these medications into that online program.
Okay.
It will give us a list of the medications, what they do, their interactions with each other,
Holy Toledo.
but most importantly, their interactions as they relate to dentistry.
Wow.
Do I have any local anesthetic precautions? Do I have any bleeding concerns?
Okay.
So a lot of the medication, there are 3 basic causes for xerostomia.
Okay.
Medications, and medications.
Okay.
And so when we have that patient that has rampant caries, that has things, we'll look to say, what are you on that may be causing dry mouth or xerostomia? LexiComp is also good for an entire clinical reference library. So they have books of oral surgery and oral and hard soft tissue diseases.
Okay.
They also have a new visual program that actually helps you diagnose oral lesions. So, I know about you, but in my practice, you'll see something, and you're a white lesion, and you're not sure exactly what it is. And they'll have ways that you can enter in and help develop a differential program.
Okay. All right.
There weren't many competing products that really allow this to standardize
And
it.
how recently did you evaluate this?
Several years ago.
Okay.
But we continue to evaluate, monitor it and evaluate it, and we have not seen anything that really will compete with that.
And right now it's 2013, so just as a reference point.
Yeah, absolutely. One of the problems.
Just get clinician's report, and then you'll always stay updated.
Yeah, absolutely. But that's one Just Get. It just helps me immensely in my practice, to differentiate
We'll get that Monday.
all these medications. LexiComp Online for Dentistry.
Right.
That is one of the problems, like we said, when we have evaluate new products, and what I'm saying today may be different tomorrow.
Absolutely.
That's how rapidly it's changing.
You bet.
Like probably the most largest paradigm shift that has occurred in dentistry in a long time has been the shift now to full zirconia crowns.
Right, we were just talking about that.
Yeah, we're seeing a major change. I like to reference Glidewell Laboratories, not because I have any particular bias or affiliation with them. It's the fact that they're the largest lab in the United States.
Okay.
And they've done over a
Certainly
million.
get a lot of mailings from them all the time.
Yeah, almost 1.5 million crowns a year.
Wow.
They do.
Okay.
And what we've seen is in 2007, they did around 64-65% PFM.
Right. In what year?
In 2007.
2007, 6 years ago. Okay,
Yeah,
5 years
okay.
ago.
In 2012, they did 74% all ceramic.
Wow.
All ceramic.
And
We've now
primarily the zirconia.
full zirconia. We've seen full zirconia now be more popular than PFMs.
Wow.
It has a
Of
much.
course, I go back with all the scars from the ones that
That didn't work.
and
Yeah, Dicor and Dicor was notorious for not working.
But they are working
the
now, and
clinical,
you can even feather edge them now. Yeah.
We have now had a couple years studies on these, and we're showing literally no chips or breaks.
Right. But these only go back about 3 years.
One of the problems
The
with
long-term studies aren't there. But the short-term studies look
Yes.
great.
The clinical observation is excellent. The science is excellent.
Right.
Don't throw PFM out yet.
Yeah.
Probably one of my biggest needs.
Don't throw full gold out yet on
No.
the second molars, especially. Yeah.
Very interesting. They did a study with the American Academy of Aesthetic Dentistry. And these are the aesthetic boys.
Oh, yeah?
And they said, what would you do in your own mouth to lower second molar?
Yeah.
So they said gold.
I've done gold on mine, and
Yeah.
I often recommend, especially if they've broken a tooth. If they've broken one of those molars, I definitely put gold in. I just
Absolutely.
tell them, well, you broke this, you're going to break the porcelain, so let's just make something that works, unless
Yeah.
they really have an aesthetic
And
concern
they-
on their second molar.
And they moved on. Lower first molar gold,
Yeah.
upper second molar gold, upper
AACD you're talking?
no, aesthetic dentistry.
Oh, okay. All right.
American Academy of Aesthetic,
Aesthetic
Dentistry.
dentistry, okay.
Upper first molar, that's when they started changing, PFM.
Okay.
Now the premolars, lithium disilicate. Now we haven't talked about that. That's Emax.
Okay. Yeah.
It's more translucent. It also has high strength, not as
Right.
not as strong as zirconia.
Right.
We'll use that a lot of times in our anteriors.
Okay. Yeah, upper anterior.
Upper anteriors, premolars. It's a very durable. It's been proven for single units.
Right.
We are showing higher fracture rates for bridges.
For the Emax.
Right,
Oh,
for
for Emax bridges. Okay.
Emax.
What about zirconia bridges?
Zirconia bridges have failing slightly higher than PFM. I don't think they're statistically significant.
Okay.
A lot of it has to do with the connectors, so it's got to be designed right with the bridge itself.
So you got to have good lab doing it.
Yeah, one of the early downfalls of full zirconia was the aesthetics.
Yeah.
It was often criticized as a monolithic restoration,
right.
and as a result, it was opaque, chalky.
Right. Okay, sure.
We now have things such as shaded Bruxer, which now is developing better aesthetics.
Okay.
We're working on internal staining, where the stain or the color will come from the inside,
Right.
not just the outside. So it's my full.
So in your own anterior, what would you put there?
If it was a single crown,
Okay.
okay, the most aesthetic crown is probably still Empress Aesthetic.
Okay.
Okay, now that was very successful, used a long time. The major reason for that is it tends to pick up the color of the underlying tooth. It's the most translucent. I would have no hesitation to use Emax, lithium disilicate. If I was doing 6 units,
Right.
6 to 11, I would do Emax.
Okay.
I would do Emax.
What about an upper anterior bridge?
Upper anterior bridge, right now I would either do PFM or I would do zirconia with a ceramic overlay. Now that's the old Lava, Sericon, Everest.
Right.
They had early problems with the external ceramic. It's not occurring anymore.
Okay.
They've modified that. We found that there's one ceramic CZR press that has proved to be extremely successful and compatible with the full zirconia. But I like pushing the envelope once in a while, so I would not hesitate doing an Emax bridge, 3-unit bridge, if the occlusion was right in the anterior.
Lower anterior.
Lower anterior, again, would go with Emax, lithium disilicate.
Bicuspids.
Emax.
I'm not hearing a lot of zirconia here.
Zirconia mainly in the posterior.
Okay.
Mainly in the posterior. As it's getting more aesthetic, I'm moving it forward.
All right.
I'm moving forward.
And what on your second molars? What would you like?
I'd go gold.
Okay.
I would go gold, but it's being challenged strongly by the full zirconia.
Okay. All right.
Absolutely.
Well, this is good information from the guy that knows here, so that's wonderful. Well, okay. Anything else before we close here? Come on. We're really giving some good information here, Michael. I appreciate it.
You know, our testing is very strong on the desensitizers. And there's one that really stands well above the rest, and that's the 5% glutaraldehyde, 35% hydroxyethyl methacrylate.
Give me a name that
Gluma.
I know.
Gluma is better known. Gluma held the patent for many years. Dr. Finger out of Germany helped develop it. What we're finding is it's a very, very potent desensitizer.
Right.
But it's also an antimicrobial. It's a disinfectant.
You're talking for class 5 braided lesions and things like this, or
under all my composite restorations.
under your composite restorations,
as a
you put
desensitizer and a disinfectant.
What composites are you using?
Right now I'm using the True Nano Hybrid, which is a Filtech Supreme Ultra.
Okay.
That has long been truly the only really nano composite. We're seeing some challengers now. Herculite Ultra is really, in some of our class 2 resin studies, is really proven very successful.
Okay.
I'm the type that I like using what I would call a universal composite. You know, I won't have a composite for my anteriors and a composite for my posteriors.
Right.
What I like about a nano hybrid like Filtek Supreme Ultra is I get the strength,
Yeah.
the wear, and the polishability.
Okay. What about class 5 lesions?
Class 5,
fractions.
depending on the patient, if there is a moderate to high decay rate, I still like the resin modified glass ionomers.
Give me a name.
Fuji 2LC.
Okay.
What we're finding, there's another unknown called Riva, R-I-V-A.
Yeah.
What we like about that is it allows us to work with it almost right away. Some of these resin modified glass ionomers, when if somebody starts using them, they'll say, "Whoa, that's too sticky. The handling, I can't handle these. The handling's bad." You need to let them wait. So a lot of times, if I'm using a traditional resin modified glass ionomer, I'll tell my assistant even before I finish the prep, start mixing.
Okay.
So then, as I'm finishing the prep, that has already mixed. The setting time has begun, so it has the consistency I need to place it.
Okay.
Now Riva seems to have that initial consistency where I can pack it in.
Okay.
So I don't think we use enough resin modified glass ionomers.
What about a base?
Well, we have two. We have a traditional, again, as a liner, a resin modified glass ionomer, Vitrobond Plus.
That's what I use.
It's been my classic.
Yep.
We now see a challenger.
Okay.
We
what is
see
it?
it's Theracal
Okay.
by
Yeah,
Bisco.
Heard of it. Heard
Okay.
Of it. Yeah.
It's the old MTA, mineral trioxide aggregate.
Yeah.
It doesn't release fluoride, but we're starting to think that the calcium content may be important to dentin than the fluoride itself.
Okay.
It's easier to use, doesn't come in a clicker, easy to dispense, has a good film thickness, and relatively inexpensive. Now this is a case, again, where the science is in,
Right.
but we're waiting for the clinical.
No long term.
But I'm starting to use that for some of my deeper preparations as a liner, especially with my pulse
Cement.
capping.
What cement are you using for your crown and bridge?
80% of the time I'll use a resin modified glass ionomer cement.
Give me a name.
Reliax luting.
Okay. That
Okay.
seems to be the most popular out
Yes, the
there. I'm
newest
using Fuji, but Relax. seems to
Fuji
be-
is excellent.
Yeah.
They're neck and neck
Right.
in comparison.
Fuji Plus, I think they call it now. or
Yes,
something like
yeah, and it's mixture now. Reliax it's Reliax Plus Auto Mix.
that. Okay.
So it's no longer the clicker. It's easier to mix.
Yeah.
It has now some low tertiary amines, so when I put it in and cement it, I can actually tack it with a light.
Okay.
So I can start cleaning it out right away.
Okay.
Okay.
Yeah.
For my resins, I'll use a self-etching resin.
Okay.
That's where the primer is inside the resin itself.
Right. I do too. What do you use?
Unisem 2.
Unisem too. Okay.
Okay. Now Unisem took a lot of problems at first. It wasn't the cement that it needed to be.
Yeah.
Manufacturers saw that. Now with the Unisem 2, it's a very easy cement to use. Maxim Elite by Kerr is another very good product. Simple to use. You put it in the crown.
Mm-hmm.
Now one of the controversies we're having is how do you cement these Emax crowns? How do you cement these full zirconia
Right,
crowns? There's
right.
no consistency.
Right. Right.
So what we're looking at is we got to roughen these crowns up, okay,
Rough.
for adhesion. If
Okay.
it's a
The
non-retentive
lab
prep.
does this. You don't do this in your office.
Well, combination. If it's an Emax,
Yeah.
the lab should use a hydrofluoric acid etch, okay, and
Yeah,
that etchant
right,
will roughen it up.
Absolutely. Yes.
If I have significant contamination,
Then you've got to re-etch it.
then I'll do it. Not phosphoric. We want to use the hydrofluoric acid
Right.
etch.
And
Okay?
this is what, like 6 or 9%, something
Yeah,
like that?
yeah. It's pretty potent. It's pretty potent. If it's full zirconia,
For less than a minute too.
yes.
Yeah.
Full
We're
zirconia.
going there too long.
Full zirconia, you want to use a sandblaster to roughen it.
Okay.
Now, what we're finding with full zirconia is if you try it in, now these are for non-retentive preps. The problem with full zirconia is it's a bear to cut off. I don't know if
Yeah,
you've
yeah.
ever cut
Yeah,
one
yeah,
off,
yeah,
but it's a bear.
Yeah, yeah.
So if you're going to use if it's non-retentive prep, I wanted to use either a sandblaster or something called IvoClean. Now, IvoClean, what we're finding with the full zirconia is the phosphate groups in the saliva will bind to the zirconia,
Okay.
tie up the ability to bond. So the IvoClean or the sandblaster cleans them out.
Sandblast. What sandblasters?
Microetcher.
Okay.
I just use a basic microetcher, aluminum oxide.
Any particular company?
Danville.
Okay. Sure.
Yeah, Danville. And then if I want to prepare my surface, I'm going to silanate the lithium disilicate.
Okay.
And Interface to me is the best
Interface,
silent now. It's a
right.
John
You
Kanka product.
got it, yeah.
So really, it's two bottle system.
Did we talk about the what do you call it, a sealer or the etchant sealer under a composite? Have we talked about that yet?
No, I don't think
Okay.
we did.
What do you use for that?
I think there's been another little bit of a paradigm shift occurring. For the longest time,
There's all-in-one, or there's a two-step, or
yeah, for the longest time, I used a 6th generation bonding agent, Clearfill SE bond.
Yep, that was very popular.
Probably the most popular out there.
Right.
Very successful,
Yep.
no sensitivity.
Yep.
Had two problems.
Okay.
One was the film thickness, about
Okay.
40 microns film thickness.
Okay.
So it was pretty thick
Okay.
and radiolucent.
Ooh,
So if
okay.
I got a little bit underneath the restoration,
Yeah,
sometimes it was
couldn't
hard
tell.
for me to differentiate.
Okay, tell me about infection control now.
You know, we were disappointed when we saw Lysol,
Okay.
which had that high ethyl alcohol content, reduce the amount of ethyl
Oh, they did,
alcohol.
okay.
And so as a result, it did become as good as surface disinfection.
Okay.
Because it was one of the few that killed everything in the presence of blood.
Right, I remember. Yeah, that's a long time ago. That
Yes,
came out.
and
Yeah.
when that whole idea is in a state of shift.
Right. So what about universal adhesives?
Yeah.
I know there's Clearfill SE, which has been a real popular one. There's Prompt Pop, Brush and Bond.
Yeah, now the Clearfill SE is a 6th generation because it's a 2-bottle system.
Okay.
The Prompto Pop is a 7th generation because it's a single bond system.
Right.
Now we have a whole new classification called universal adhesives,
Universal adhesives.
of which
Okay.
Scotch Bond Universal is
Okay.
probably the one that I'm using now. It's a single component system.
Yeah.
They're claiming a universal bond because it bonds to lithium disilicate, it bonds to zirconia, it bonds to alloys.
So you're putting this under all those, not just composite. You're putting it under.
You can put in and get a bond. Here's one of the major things we're finding. For the first time in our bonding studies, we're finding a dentin bond that's retained for at least 6 months
with this.
with the universal adhesives. It's something that has not happened before.
So give me some examples of these universal adhesives. Scotch Bond Universal.
Universal OptiBond XTR
Okay.
from Kerr. In one of our studies, OptiBond XTR was the strongest bonding agent
Okay.
that we had. It has a low film thickness. It's inexpensive. And again, it's a 1-bottle system, so we're switching over these. Now, you got to be careful when you call these universals because
Right.
if you want a dual cure component, you got to add a separate
Okay.
etchant.
So if you're doing a composite, you're using the Vitrabond or something like that
For the deep preps.
For the deep preps, and then you're using what?
Well,
What's the next
a
step?
typical composite preparation will be, I will prepare it,
Yep.
we'll rinse it, isolate it,
Right.
the glutaraldehyde
Okay.
first.
Gluma.
Yeah, like the Gluma.
Okay.
And then I'll apply the universal adhesive
Okay.
And-
Does Vitrabond come before or after the Gluma?
after,
Okay, so Gluma, Vitrabond, universal adhesive,
and then your composite.
then the composite.
Now, not to confuse you, that's a self-etch technique. And there are two
Right.
other techniques. There's a total etch
Okay.
and there's a selective etch.
Okay.
And I can use my universal adhesive with either one.
Okay.
Now, a total etch means I'm etching everything.
Right.
Okay, and that was
Pigment and enamel, everything.
very popular with some of the earlier systems.
Yep.
Still popular, still a good technique. Problem I have with that is you got to plug the dentin tubules.
Yeah. Absolutely.
That's the point. If you open them up, you got to plug them. Selective etch, for good examples, on a class 4 break.
Okay.
I'll etch the enamel only,
Right.
rinse it
Do
off,
that all the time. Yeah.
and then I'll go back in with my universal adhesive.
Universal adhesive. Okay. All right. Now beveling. Do you bevel the enamel bevel on the proximal box? Or
Well,
the occlusal,
not
or what? What do
not
you
for
bevel?
class 2s. We're finding that a bevel is not necessary for a class 2 preparation.
Holy cow, okay.
Now, if I'm doing a class 4, I want a bevel,
Yeah.
and mainly for aesthetics.
Yeah. Okay.
Yeah,
sure.
but as far as beveling in a standard class 2, the answer is no.
Okay. All right. All right. Very good. Class 5s, no bevel on the enamel. Okay.
No, but what we found is mechanical retention is still important. So one of my favorite armamentariums is a simple quarter round burr.
You know what? Everybody says, so many people say you don't need it. I still use it. I guess I'm just a perfectionist.
We still
I
do.
just like that, confidence.
And there's nothing wrong with that.
Okay,
Especially like I said, with just our study showing for the first time we're getting some retained dentin
Yeah,
bonding.
yeah.
Used to be hot, cold, hot, cold, hot, cold. There was no dentin bond.
Right. Okay.
It was fictitious.
Okay. All right. What are we missing here? What else can we help with here?
I think we covered. There's some things in the Crown and Bridge armamentarium with disposable diamonds.
Okay.
That's a big important thing for me. You know, I'm looking at diamonds, the Neo diamond for microcopy, the Spring Health diamonds, $1.75 to $2 a diamond,
Okay.
are as effective or sometimes better than the more expensive diamonds.
goodness, okay.
And it's nice to have a new diamond for every patient.
You bet.
And they go multiple preps.
Okay.
They go multiple preps.
All right, super. Well, if you need it, how do we get in touch with you all? Okay, I mean, you or Clinician's Report, or
Yeah,
how should we go about
you
this?
certainly can call Clinician's Report.
Okay.
Somebody can call me directly
Okay.
at my office.
All right.
They can email me. Be more than happy to answer any questions
What's
they
the
have.
website for Clinician's Report?
It's www.cliniciansreport.com
Cliniciansreport.com.
or .org.
.org.
Yeah.
Cliniciansreport.org. Okay. Get with Clinician's Report. Just sign up for that. You really do need that. They're unbiased. They so many products they evaluate, and they really give you the best techniques and the best products and the best way to do it. Mike, is there any last things that you'd like to say before we close?
Just thank you for this opportunity, and I want to thank Woody for this opportunity
great
to be at Excellence in Dentistry. It's an excellent meeting.
All right, Mike, thanks
Good.
so much
Thanks,
for being
Mike.
with us.
Thank you so much. Thank
Okay.
you.